Welcome to Drugs Decode. Today, we're diving into a real-life clinical pharmacy case study. Let's find the clinical issues and interventions. Scenario 1. I give you a minute to read and understand. Okay, meet Mr. Silva, a 58-year-old male diagnosed with hypertension, type 2 diabetes, and hyperlipidemia. He has been on metformin 500 milligrams twice daily, amlodipine 10 milligrams once daily, and atorvastatin 20 milligrams once daily. Upon assessment, his blood pressure was 158/95, his fasting blood glucose was 140 milligrams per deciliter, and his HbA1c stood at 7.2%. Additionally, his LDL cholesterol was 130 milligrams per deciliter. Did you find any issues? Yeah, despite medication, he experiences high blood pressure and ankle swelling, and blood glucose level is a little bit higher. So, we need to modify his medications. Let's see the clinical issues and intervention. After analyzing his condition, the pharmacist recommended 4 key interventions. First, adding ramipril 5 milligrams once daily to improve blood pressure control and kidney protection. Second, reducing amlodipine from 10 milligrams to 5 milligrams to manage the ankle swelling while maintaining blood pressure effectiveness. And third, optimizing diabetes and lipid management by increasing the atorvastatin dose 20 milligrams to 40 milligrams and providing dietary counseling. HbA1c is slightly high, indicating suboptimal glucose control, where we need to increase the metformin dose, or we can add another class of anti-diabetic drugs like empagliflozin, which may help to reduce the lipid level also. This case study highlights the importance of clinical pharmacists in optimizing therapy and improving patient outcomes. Scenario 2. I give you a minute to read and understand. Okay, a 55-year-old male with a history of hypertension, diabetes, and chronic kidney disease. He presents with severe headache, blurred vision, shortness of breath, and reduced urine output. Let's look his vital signs. I give you a minute to read and understand. Okay, blood pressure, 220/130, it's elevated. Heart rate, 98 BPM, it is also high. Respiratory rate is 22 breaths/min, normal. He has mild confusion, hypertensive encephalopathy. Fundoscopic exam shows hypertensive retinopathy with hemorrhages and cottonwool spots. ECG indicates left ventricular hypertrophy. These symptoms and findings suggest a hypertensive emergency, a condition where severely high blood pressure is causing acute organ damage. Hypertensive emergencies occur when blood pressure rises to dangerously high levels, typically above 180/120 mmHg, and causes damage to vital organs like the brain, heart, kidneys, and eyes. Do you know the differences between hypertensive emergency and urgency? Hypertensive urgency is severe hypertension without organ damage. It can be managed with oral medications. But hypertensive emergency is severe hypertension and acute end-organ damage. This condition requires IV therapy. In our patient, we see multiple signs of end-organ damage. Let's break it down. Brain, hypertensive encephalopathy, confusion, headache, risk of stroke. Heart, left ventricular hypertrophy, heart failure, pulmonary congestion, chest discomfort. Kidneys, acute kidney injury, rising creatinine, oliguria. Eyes, hypertensive retinopathy, flame hemorrhages, blurred vision. If not treated immediately, hypertensive emergency can lead to stroke, heart failure, or even death. Managing a hypertensive emergency requires a structured approach to lower blood pressure safely without causing ischemia. Here's what we do. Immediate goals, first 1 to 6 hours. Reduce BP gradually, not too fast. Avoid cerebral ischemia. Prevent worsening of organ damage. Closely monitor in an ICU setting. First-line IV medications, emergency BP control. Nicardipine, IV infusion, first-line calcium channel blocker. Labetalol, IV bolus or infusion, useful if neurological symptoms present. Nitroprusside, IV infusion, effective but avoidant CKD, cyanide toxicity risk. We aim to lower BP by less than or equal to 25% in the first hour, then gradually to 160/100 mmHg within 6 hours, and finally normalize BP over 24 to 48 hours. Long-term BP management. After stabilization, the focus shifts to long-term BP control to prevent recurrence. Oral medications. ACE inhibitors, or ARBs, lisinopril, losartan, protects kidneys. Amlodipine, effective for BP control. Thiazide diuretics, chlorthalidone, indapamide, reduces fluid overload. Lifestyle modifications. Salt restriction, 2g/day. Diet and weight control. Exercise and medication adherence. Skipping medications is a major cause of hypertensive crises. Always educate patients on adherence. That's all for today. We will continue our next session with Scenario 3, where we can perform the role play and extract the issues from the patient history. Don't forget to like and subscribe our channel. Stay with us.